Moving on, we have the next session on cardiovascular risk in dyslipidemia, conducted by Dr. Chandrike Ponnamperuma, consultant cardiologist. And I kindly request Dr. Asela Anthony, consultant family physician, and Dr. Namal Vijayasinghe, consultant cardiologist, to chair the session. Pardon me. Dr. Malkanthi Galhena, the president of the college, to chair the session. And I cordially invite Dr. Chandrike Ponnamperuma on stage.
Dr. Chandrike Ponnamperuma is a consultant cardiologist working at the Colombo South Teaching Hospital, and he is the current president of the Sri Lanka College of Cardiologists. He'll be talking to you on managing dyslipidemia to reduce atherosclerotic cardiovascular disease. Over to you, Chandrike.
Thank you very much for those words of introduction, and I should thank the President, Council, and the Academic Committee of the College of Specialist Family Physicians for giving me this opportunity. And I hope this will make a difference in the way you look at lipids after this lecture. I'll start with, I have no conflicts of interest. And this is a story of a 58-year-old doctor who presented with chest pain one afternoon to the emergency unit. He gave a history of diabetes mellitus for 15 years. He's a non-smoker. He didn't have a history of hypertension or dyslipidemia, but had a family history of ischemic heart disease. His father has had a myocardial infarction at the age of 60s. He has been on metformin, 1000 milligrams twice a day, glycoside 40 milligrams twice a day, sitagliptin 50 milligrams MANE, and atorvastatin 5 milligrams nocte. Mostly self-medicated, as most of our doctors do. So the ECG showed ST elevations in anterior chest leads and reciprocal ST depressions in inferior leads. I am sorry, I don't have that ECG at the moment. And it's diagnostic of ST elevation myocardial infarction. So for ST elevation myocardial infarction, best treatment is a primary PCI. This patient came to a hospital which has a cath lab, so was taken to the cath lab, and this was the angiogram. So you can see, is there a marker, pointer? A pointer. You can see the left anterior descending artery is totally blocked here. Only one video is working, the other also showed it was totally occluded. So we took him for primary PCI, and this was the final result. It was quite complex disease, which was including left main and both vessels, both LAD and circumflex, and we had to do a complex PCI from left main to with the involved in the bifurcation. And he recovered quite well. So he had some results with him, lab reports, which he has done few weeks back. His hemoglobin was 12.8, fasting blood sugar was 118 with HbA1c of 6.4%, fairly well controlled diabetic. His liver enzymes were normal, creatinine was normal, and the urine albumin creatinine ratio was 68. So there has been some end organ damage due to diabetes with proteinuria. This is his lipid profile report. Total cholesterol was 203 milligrams per deciliter. If you look at this normal range, it's within normal. He was very happy about his lipids actually. His LDL was 139.9, that is what we go by. And still within the normal range given in the report. And he told me that he was actually thinking of why he is taking this atorvastatin, and he was thinking of stopping it because he had some myalgia with it. He attributed it to the statin. So the question is, should this patient had got a myocardial infarction at this age, being a doctor, being a diabetic, and have we failed in preventing this myocardial infarction in this patient? Is it, I think he was treated mostly by self, but these patients, we all face with these patients, And a lot of our patients have myocardial infarction in spite of we being treating. So whether we consider that as our failure. So could we have prevented this? So, I'm sorry, the pointer is not very clear here. So the top figure is a normal artery. So about 15 years ago, at the age of around 43 years in his case, his artery would have been like that top one, which has a normal intima, normal media, and a normal looking vessel, no atherosclerosis. Then he started getting diabetes. As you know, a lot of these risk factors, hypertension, smoking, diabetes, air pollution, everything leads to endothelial injury, endothelial dysfunction. When there's endothelial injury, there's inflammation occurs in the intima of the vessel wall, and these white cells, particularly macrophages and LDL cholesterol, then smooth muscles from the lower layer migrate into the intima, and these LDL particles gets oxidized, and this is a bigger picture. LDL particles get oxidized and form foam cells. Then there's some collagen synthesis going on. Smooth muscles migrate from the media through the internal elastin lamina to the intima and forms the cholesterol plaque. So from the normal artery, it moves on to a fatty streak, a fibrofatty plaque, and advanced vulnerable plaque, and that is there, and changes in the vessel wall can occur. There could be, the vasa vasorum can get blocked and cause weakening of the wall, and aneurysms can form. Plaque, as it enlarges, it can encroach the lumen and cause stenosis. And there could be occlusion by thrombus. What is shown by arrow is where our patient is. That's what happened to the patient. And we have failed to prevent this from happening in this patient. And he ended up getting a myocardial infarction. We have managed the hyperglycemia of diabetes well, but we have not considered the atherosclerotic cardiovascular disease risk of this patient. That is the problem. And we have failed to prevent atherosclerosis. So how do you know the cardiovascular disease risk? How to estimate? We have 3 guidelines to go by. One is the clinical evaluation of the patient. What risk factors does the patient have? Like already having documented cardiovascular disease, past of TIA, peripheral vascular disease or angina. Whether they have diabetes, moderate to severe renal disease, very high levels of individual risk factors like familial hyperlipidemia, or a high score in the risk score. Then there are risk scores which we can use. I will show you one, what is applicable to us, and what is used in Europe is score, and whether we should estimate the 10-year risk estimate, and that will give us a estimation of the probability of this patient getting a cardiovascular event during the next 10 years. And in addition to that, we can use other assessment of other risk modifiers. There are other blood tests which we can do, like lipoprotein B levels, lipoprotein small a, C-reactive, high sensitive C-reactive protein levels, and we can go for imaging like CT coronary angiogram to see whether there are any plaques, and also carotid intimal thickness in a carotid Doppler can be used as markers of these risk. So we have not done any of these in these patients. We very rarely only see patients who have undergone this degree of assessment, which is important to identify these patients at an early level where we could prevent these events. So there's good evidence. This is from ESC lipid guidelines, and this is class 1 level C evidence for these, class 1 recommendation. This is the WHO cardiovascular disease risks for laboratory based risk chart, which is applicable to us in Southeast Asia. So here we consider in 2 segments whether the patient on on your left hand side is patients without diabetes, and on the right side is patient with diabetes, again divided into male and female, and again divided into smokers and non-smokers. So to estimate the 10-year risk, you select the appropriate chart depending on the presence or absence of diabetes, then select whether it's male or female, select whether it's smoker or non-smoker, and select the age group box, most appropriate age group, and within this box find the nearest cell where the individual's systolic pressure and the total blood cholesterol levels cross each other. The color and the number of this cell determines the 10-year cardiovascular risk. So where did our patient stay? Our patient was here. He was a patient with diabetes. He is 58 years, so 55 to 58. He is a male, non-smoker, and his cholesterol level, which was checked few weeks back, was 203. So you can, this is given in millimoles. How you convert this? You divide by 39. Milligrams divided by 39 becomes millimoles for cholesterol. So his in millimoles it is about 5. So little more than 5. Therefore, his 10-year cardiovascular risk was 10%. That is, if there were 10 people with that risk, one of them is going to get a cardiovascular event during the next 10 years. So that is a fairly significant. I don't think if you have family members of 10, you don't want one of them going off within the next 10 years, isn't it? So it's a fairly significant risk. So depending on these factors, we have to identify these patients, whether they are very high risk, moderate risk, or low risk. We'll have a look at these. So if the patient has already documented atherosclerotic cardiovascular disease, either on clinical grounds or on imaging, without any doubt, that forms high risk. So documented ACVD includes myocardial infarction, unstable angina, stable angina, having to undergo PCI or bypass surgery, stroke, TIA, peripheral vascular disease, or if you see a lesion more than 50% with multivessel coronary disease or on carotid ultrasound. If they have, that is documented atherosclerotic cardiovascular disease. If they are diabetics with end organ damage with 3 or more major risk factors or early onset of type 2 diabetes for more than 20 years, they fall onto the very high risk group. If they are severe CKD, they fall into this very high group. And when there is a family history of atherosclerotic cardiovascular disease with another major risk factor, they form into this group. Or if there is 10% or more 10-year risk of fatal CVD, they form into this very high risk. So our patient was obviously in this very high risk group because they had a 10% risk. High risk people is markedly elevated single risk factor, like total cholesterol more than 310, LDL more than 4.9, or blood pressure more than 180 by 110. Patients with family history without other major risk factors, patients with diabetes without target organ damage, and with diabetes mellitus duration 10 to 20 years. 20 years falls onto the other group, very high risk group. Moderate CKD or calculated risk score of 5 to 10%. Moderate risk group is young patients with type 2 diabetes less than 35 years, type 1 less than 35 or type 2 less than 50 with diabetes duration less than 10 years without other risk factors, and a calculated score of 1 to 5%. Low risk is calculated score of less than 1%. So it is important to divide into these 4 groups because our lipid threshold, the target of our lipids will depend on this risk category. Right? This is a summary of this. Very high risk is calculated score more than 10%, 10% or more. High risk 5 to 10, moderate risk 1 to 5, and low risk less than 1%. So there are some factors which we take as modifying these core risks, like there's a family history of premature CVD, elevated biomarkers. So those are secondary. I would mind even you forget this slide. The more important is to go by the other risk score and identify the high risk patients. So when you manage these patients, on this side of the chart is the risk level, on top is the low risk, then moderate risk, then high risk, after that very high risk, right? So top part is for primary prevention, the last row is for secondary prevention, right? So when you are managing these patients, and on the columns are for different cholesterol values. You go by that. You can start with lifestyle advice for the ones in green. Without starting medication, you can try lifestyle advice, that's dietary and exercise advice for 3 months, then repeat lipid profile and check. For the yellow group, you have to, in all those, you have to give lifestyle advice, but you consider adding a drug. For example, for the very high risk group, when the cholesterol level is more than 55 milligrams per deciliter, for secondary prevention, you start adding a drug. For primary prevention, when the cholesterol level is more than 70 millimeters mercury, for the very high risk group, you start adding a drug. And the groups in red, you have to add a drug from the onset in addition to lifestyle modifications. This will be a helpful chart for you all to have in your desk to see which one you should start treatment with drugs at the outset and which ones you can try lifestyle modifications for 3 months and see. I told you before, the risk category will determine our treatment target, which is in secondary prevention. So the secondary prevention is always at very high risk group, that is those who have had atherosclerotic cardiovascular disease before. So their treatment target is 55 milligrams per deciliter LDL. All these goals are primarily for LDL level, and in addition you also can take the non-HDL cholesterol level, and the target is always 30 milligrams per deciliter more than the target for 55. For example, in secondary prevention, the target is 55 milligrams per deciliter. If you take LDL cholesterol, if you take non-HDL cholesterol, it should be 85 milligrams per deciliter. For primary prevention, people at very high risk group, again your treatment target is 55 milligrams per deciliter. For patients with atherosclerotic cardiovascular disease who experience a second vascular event within 2 years, you have to drop the LDL level up to 40 milligrams per deciliter. That is, it need not be in the same vascular territory. Say your patient gets a heart attack or unstable angina, you treat with LDL and bring it down to 55, and within 2 years he gets a transient ischemic attack or a stroke. So he has had 2 atherosclerotic events within 2 years, then your LDL target is 40 milligrams per deciliter, right? Some guidelines I have seen 0 to 40, right? So for individuals at moderate risk, your LDL target is 100. So for very high risk, your LDL target is 55. For high risk, LDL target is 70. For moderate risk, your target is 100 LDL target, and for low risk individuals, your LDL target is 116. It is the same thing is shown in this slide. So what are the LDL lowering drugs you can use? Statins are the mainstay of treatment. Then ezetimibe is available here. Other 3 drugs, bempedoic acid, PCSK9 inhibitors and inclisiran are not available to us. So statins and bempedoic acid work on this HMG co-reductase pathway, LDL producing pathway in the hepatocyte. Bempedoic acid blocks it in the ATP citrate lyase level, and statins block it in the HMG CoA reductase level. Both act in the same pathway and both can be used when LDL and ezetimibe combination is not working, next step is to add bempedoic acid, if it is available. It's available in India. Ezetimibe works differently. It prevents absorption of cholesterol from the intestines. Dietary and biliary cholesterol absorption from the intestine is blocked by ezetimibe. PCSK9 inhibitors are not available to us, alirocumab and evolocumab. Those work by blocking destruction of LDL receptors in the hepatocyte, so that when you give these drugs, there will be more. PCSK9 is a protein which gets attached to the LDL receptor, and when the LDL particle gets attached to the receptor and when it's engulfed into the hepatocyte, if there is a PCSK9 protein bound to that LDL receptor, that will get destructed. What PCSK9 inhibitors do is, those are monoclonal antibodies. They will bind to this PCSK9 protein, and therefore the LDL receptor will not get bound to it. Therefore, the LDL receptor will not get destroyed. It will come back to the surface of the cell membrane of the vessel again, and which will bind more and more LDL. Therefore, more and more LDL will be destroyed in the hepatocyte. That's how PCSK9 inhibitors work. And those are very potent agents to reduce, and good evidence that it reduces atherosclerotic CVD events. Inclisiran is a mRNA, and it binds to, again it goes to the hepatocyte, and it prevents PCSK9 production. It blocks the PCSK9 production. Therefore, no PCSK9, and LDL receptors will not get destroyed. Therefore, hepatocyte will destroy more and more LDL. But those two drugs, PCSK9 inhibitors, bempedoic acid, PCSK9 inhibitors, and inclisiran are not available in this country yet. So, back to the question, could we have prevented the STEMI of this index patient? We failed because, we have failed definitely. We failed because the 10-year atherosclerotic CVD risk was not considered in the setting of lipid targets for him. He was very happy about his lipid profile, total cholesterol 200, because it was within the normal range given in that report. And reference rate given in the lipid profile was used as the guide. So, these are various cholesterol reports. I think Dr. Dharmaratne is there, DDG Laboratory Services, and we had a discussion, and we are in the process of changing this from college. So, these are various lab reports. So, these patients, when we treat, their LDL drops to 60 milligrams per deciliter. We are trying to get it down to 55. What happens? The patient does a lipid profile, and it comes with the repeated and confirmed also highlighted, because the lab thinks that this is abnormally low for this patient. Patient is extremely nervous. There are a lot of myths about cholesterol and lipid lowering agents in the society. They run with this report to you all who are the closest to their heart. We are quite distant to them, right? And sorry to say, some of you all stop the statin, because they also believe on this reference value. So, this is from Colombo. That is our government lab giving a reference range. They put them, they are Anuradhapura. Courtesy Dr. Mubarak. He has this collection from all over the country. He is working on this with the college to stop this. Have a more rational guideline based reference range on these reports, right? And this is one main obstacle for us to maintain the desired lipid levels in these patients. In summary, management of dyslipidemia is important to reduce atherosclerotic CVD risk, because what all other risk factors you talk about, let it be diabetes, hypertension, air pollution, smoking, what all those do is endothelial injury. Rest of it is done by the lipids. LDL will escape through that endothelium and cause deposition. So, you have to keep the LDL low. LDL is the primary target for intervention. the target of LDL depends on the patient's atherosclerotic CVD risk profile. Higher the risk, lower should be the target. Dietary and lifestyle modifications are essential irrespective of lipid levels to reduce ACVD risk in the community. Statins remain the mainstay of treatment of dyslipidemia. Ezetimibe, bempedoic acid, PCSK9 inhibitors and inclisiran are useful adjuncts to statins. Unfortunately, we have only ezetimibe at present. Outdated blanket reference ranges and myths regarding statins has made it difficult to achieve targets in Sri Lanka. There are a lot of myths about statins. People are extremely worried about dementia. Most of them come and say, so I agree with them, yes, if you don't take statin, you will not live till you get dementia, but you take statin, you will live until you get dementia. That is my answer, right? These are my references. There's a national guideline of management of dyslipidemia for secondary and tertiary healthcare levels by the Non-Communicable Disease Directorate of the Ministry of Health. There the thresholds given are slightly higher than this. And ESC guidelines on management of dyslipidemia. There are a lot of guidelines. These are the tools which I generally refer, and this is what I refer. Thank you.
Thank you very much, Dr. Chandrike Ponnamperuma, for giving us very informative lecture regarding the mismanagement of the dyslipidemia, which is very important in primary care because we have the responsibility on our own patients whether to start the treatment correctly and whether to hand over the patient to you all correctly. So thank you so much. Being the president of the College of Cardiologists, your presence today gave an honor to us. So thank you so much again and wish you all the very best.
Thank you very much, sir. And the token of appreciation to Dr. Chandrike Ponnamperuma will be given by the chairpersons, Dr. Asel Anthony, and the president of the college, Dr. Malkanthi Galhena. Thank you once again, ladies and gentlemen. And we are